It's a good honor for me to be here, present for a presentation focusing on preliminary results on hereditary atrioventricular block. So this is a outline. I will give the first part, clinical classification and overview. In 1906, Tawara first described atrioventricular node. So it is considered the varistor filter and the deputy monitor in the heart. And the hereditary AV block consists of the 6 parts. First, congenital atrioventricular block, and second, atrioventricular block in children, and third, progressive cardiac conduction defect called PCCD, and the first is AV block associated with congenital heart disease and AV block associated with neuromuscular diseases, and the last one is idiopathic atrioventricular block. So when we look at the literature, before 1920, there are only 8 cases for congenital heart block. But in this review, in 1928, there are more than 20 cases of congenital heart block by lots of authors reported. And in another literature, there are more than 200 congenital heart block. Most of them are a complete heart block, and lots of them are fatal. So the congenital AV block, the incidence is approximately 1 of 20,000, and more than half are caused by structural congenital heart disease, such as corrected transportation of the great arteries and left atrial aneurysm, and related to intrauterine fetal and neonatal mortality rates and long-term sequelae. And the maternal anti-Rho or anti-SSA antibodies or anti-La or SSB antibodies always be positivity. And the recurrence rate of the recurrent pregnancy is 20% to 25%. 12% to 25%. And over 95% of patients can detect maternal autoantibodies in their blood. And most mothers are asymptomatic carriers, with less of 1/3 of mothers having a history of rheumatic immune disease. And after maternal anti-Rho or SSA or anti-LA SSB antibodies enter the fetal circulation through the placenta, they can directly bind to L-type calcium channels on fetal myocardial cells, reversibly inhibiting calcium occurrence. So the long-term exposure to antibodies, these antibodies may induce disturbance in cytoplastic calcium metabolism, leading to local inflammation, ultimately leading to cell apoptosis, as well as fibrosis and calcification of the cardiac conduction system. The risk of attack and destruction of susceptible fetal AV nodes by these antibodies is highest during 16 to 28 weeks of gestational age. And the death of congenital AV block mainly occurs in the uterus and the first few months after birth, up to 15% to 30%. And the diagnosis of congenital AV block can be determined by prenatal fetal ultrasonography and postpartum electrocardiogram. And there are some medications like hydroxychloroquine can prevent early fetal congenital AV block and can be used in pregnant women who are antibody positive or have previously conceived a child with congenital AV block. And fluorinated steroids and dexamethasone may be also effective. So the second type of the hereditary AV block is childhood onset AV block. AV block occurred between the first months of birth to the age of 18 is called pediatric atrioventricular block or childhood onset AV block. Only a few cases of pediatric AV block can detect maternal antibodies. And in childhood and even adulthood, congenital immune AV block deteriorates with age, accompanied by subclinical anti-Rho or SSA induced congenital damage to the conduction system. In addition to autoantibody related to AV block, there is also an isolated non-immune early or late onset heart block discovered in later childhood, which may be related to specific genetic markers or other pathogenic mechanisms. So all childhood onset AV block patients, even if asymptomatic, should consider a pacemaker implantation as the first diagnosis. And so-called idiopathic AV block, that means AV block refers to unexplained AV block that occurs in childhood, lacks the evidence of maternal antibodies, structural heart disease, or other causes. And we focused on the PCCD, progressive cardiac conduction defect. It is associated with various genetic defects such as sodium channel coding gene SCN5A and gap junction protein connexin 40 and calcium channel coding gene GAV1.2 and potassium channel coding gene KCNJ2. So we are talking more about progressive cardiac conduction defect, PCCD. Look at this patient. When the electrocardiogram taken in 1982, it has just incomplete right bundle branch block. And 6 years later, the complete right bundle branch block occurred. And in 2000, in the year of 2000, except for right bundle branch block, complete, but with a prolonged QRS interval, and also has a left anterior hemiblock. And after he went to the clinic, he had got a complete heart block. So it's a progression after the AV block. And when we look at the electrocardiogram, it will reveal the first degree atrioventricular block with narrow QRS wave or wide QRS wave. But when first degree AV block with wide QRS wave, like a bundle branch block pattern, it commonly seen in infravesicular block, and some cases may involve first degree AV node block with bundle branch block, especially for those with significantly prolonged PR interval, like greater than 0.40 seconds. And we often see the electrocardiogram with unilateral bundle branch block, right or left, with prolonged PR interval. And if the PR interval are prolonged progressively, it means the PR interval prolonged do not blocked in the AV node, usually in another bundle branch. So when electrocardiogram progressed to second degree AV block, maybe Winkelbach type or maybe type. If it is a Mobius type, almost all the blocking areas are located in his Peking systems. So a pacemaker was needed. It's a class 1 indication in the guideline. And if the electrocardiogram was a Winkelbach type, it can still blocked in his Peking system. So even it is a Winkelbach type AV block, it still need a pacemaker. If the electrocardiogram progressed to 2.1 AV block, and maybe it will block at the atrioventricular node level or his Peking system level. That depends on the QRS, the interval of QRS complex, and if there is a history of Winkelbach's Winkelbach's block, or if there was a history of myocardial infection, or eos digitalis, or atropine can elevate the degree of blockage or exacerbate blockage. So we will look at the 2-to-1 blockade at the AV block, and the top one was blocked at the AV node. There isn't a H wave, and the lower one is blocked at his Peking system. So both are 2-to-1 AV block, but the lower one need a pacemaker. Also, even if QRS is narrow, the 2-to-1 blockade still can be blocked at his Peking system level and need a pacemaker plantation. If the electrocardiogram progressed to third degree AV block, it's complicated. So there are two types, with a narrow QRS complex escape or with a wide QRS complex escape. Even if it is a narrow QRS complex escape, it can still blocked in his bundle. If the escape rate was less than 40 beat per minute, or after exercise or atropine, the escape rate increased less than 5 beat per minute, or the patient has a previously second degree type 2 AV block. This is a 69-year-old female with renal insufficiency, and the 2 electrocardiogram shows right bundle branch block, and another is complete right bundle branch block. So bilateral bundle branch block occurs, and this patient has a pendulum-like bundle branch block, just like a Posadas, with a crest up and down, but it is caused by the bilateral bundle branch block. So pendulum-like bundle branch block, it could be caused by pathological factors, and it still can be caused by physiological factors. And another type of masquerading bundle branch block. That means when we look at the V1, lead V1, it is right bundle branch block, completely right bundle branch block. But when we look at lead 1 and AVL, it is complete left bundle branch block. So it is masquerading. When we look at the electrocardiogram 8 years ago, the same patient is just showing the complete right bundle branch block without left bundle branch block in lead 1 and lead AVL, and QRS is also 140 milliseconds 8 years ago. And some patient may have an intermittent complete AV block. So the syncope may occur, but if we had implanted a loop recorder, we had many cases like that. And during the following up period of 3 years, we got lots of the intermittent AV block. But when the patient had a Holter monitoring or electrocardiogram or a tilt up test, all of them are negative. So in HRS, EHRA, AP-HRS expert consensus statement on the diagnosis and the management of patients with inherited primary arrhythmia syndromes and progressive cardiac conduction defect, PCCD, was in the list of the 8 and the PCCD, usually there are lots of the cases like Landgraf's disease or Leff's disease. All of them are unilateral bundle branch block, progressed to bilateral bundle branch block and triple branch block, then complete heart rate. And there are some differences. Leff's disease usually are older than the Landgraf ones, and accompanied by fibrous skeleton hardening and partial concomitant hypertension. So it's not uncommon if the old patient with left bundle branch block and no obvious heart disease and is highly suggestive of Leff's disease. But when The AV block had a familial aggregation. It might be Legris disease, usually young, and the original site might be right bundle branch block. The left disease usually originated from left bundle branch block. So all of them are progressed to bilateral bundle branch block, then complete AV block. So we give a conclusion. Hereditary atrioventricular block is not uncommon in clinic practice, and it deserves paying more attention. And bilateral bundle branch block, more means tapped second degree AV block and complete AV block, are class 1 indications for pacemaker implantation, even without any system. PCCD patients should be closely followed up to observe subtle changes in the electrocardiograph. Thank you.